Herman, as chair. Colleagues, Herman asked me to keep this down to about 75 minutes or 75 words. We'll go for the words, shall we? Okay. 35 remarkable people spoke on a diverse range of interests that speak to, I think, and what I heard, several topics that I'd like to feed back to you. The first topic is the issue of our fundamental human rights as enshrined in our Constitution. Core to that is, number one, the rights to dignity. Subordinate to that, or supportive of that, is the rights to access to healthcare and the rights to access to the courts. And part of what we're talking about now is the question of where in our journey of the consumption of healthcare services has it disrupted to the point that we have congestion in the courts, congestion in the healthcare, and a disequilibrium in how the services are being provided and perceived. That was the first theme that I heard I speak about. I hear that theme consistently across both the road accident fund liabilities and the state liabilities as they relate to medical and medical indemnity issues. Since we're talking broadly, I did want to comment to say that the liabilities that we spoke about today and the 300 billion equates to the equal debt of the energy utility of Eskom. Their debt roughly matches this debt, and yet the exposure that we have to their crisis and our crisis are quite disproportional to each other. And that then brought out the two topics that we spoke about after lunch and the debates that we had. The first element of that debate is really, how do we define who is a person in need? We've used cerebral palsy as the example, but it is possibly a constitutional debate to expand to say, is a person who is congenitally limited, disabled, or incapacitated in any way entitled to less than a person who seeks restitution and compensation in a civil court? I don't think that's an answer that we have, but it's certainly a debate that comes up. Equal to that debate was the issue of, are the mechanisms in place to give equitable resolution to disputes in the road accident fund and in the courts? And I think it's clear that from our perspective, there is again a disequilibrium and that the mechanisms don't exist. So please shake your head vigorously if you disagree, so that I know that you're not stunned in the headlights and waiting for your coffee. The third comment to that then is the comment around, should there be a regulatory body that is separate and distinct, and where should it live? And with the deepest respect to everyone here, I don't think I can add any value. I did work for the NHSLA for a while, and what was interesting about their work is a lot of their emphasis was on risk management and the notification process. When they unbundled and they created the trust structure in the UK, largely it was because the burden, the financial burden and the access to dispute resolution was in the same crisis then as our crisis is now. There was a cerebral palsy crisis. There was a crisis on quality of care in the hospital structures. There was a crisis on education levels. There was a crisis on an understanding and trust between the various groups. There were legal representatives who would walk the corridors of the hospitals looking in the rooms to identify somebody whose chart was tracking left. Those of you who aren't medical people, tracking left means you're doing badly. So they've come a long way since then, and by rebranding in 2017 to NHS Resolution and taking a different view on how they manage cerebral palsy, the lesson that they learned, which is a lesson that we can take out, was the earlier the notification and intervention, the less likely the dispute would escalate into a conflict, and that conflict would end up in a litigation. We've got lots to learn about that. Finally, the question is, what is the role of this body and the representative people in this body? And I think if I was to summarize what I've heard spoken in the last period, it's that there are representative bodies, the Nursing Council, the HPCSA, the legal bodies and others, the Bar Association. Now, the coordination between those which are professional bodies and regulatory bodies and voluntary bodies, and this voluntary body, is going to be key in finding the right voice to take the advocacy to the right levels and the right ears and the right mechanism with the right language in order for change to be escalated and accelerated. It's clear through our colleagues from the Department of Health, and thank you for your comments, that there is a will and there is a process in place already moving towards a national litigation body of some sort in terms of health. The question is just, what do we need to do as civil society and interested parties to enhance and stimulate that political will? And what is the role of our individuals as ourselves? What is your role as a person? What is your role in advocacy through your voluntary and professional association? And what is your role through your voluntary associations to drive and activate change? Thank you very much for the time. And Mr. Chair, I'm handing it back to you. Or do I say Dr. Chair?
You say Herman. Thank you very much. The meeting is closed. What I'm going to ask everybody who spoke, many of you have sent me a one-page précis or synopsis of what you had to say. If you wish to change or amend or improve that in any way, please send me your next version. And those who haven't sent that, please send it to me. I really would like us to be able to compile a file of short introductions to each presentation so that somebody can read them and digest them quickly and know what it's about, and then supplement that with any supportive documentation that you wish. I also, at the same time, invite everybody who is not a member of SAMLA but who has interest in any way in the medico-legal area of practice to consider joining SAMLA. We are an open, independent discussion forum, and we are there to serve the public interest. Thank you very much.